had a nice overview, from Dr. White regarding a thorough evaluation of abdominal imaging, and now we're moving on to the respiratory tract, so covering most of the body here, which is really nice. So similar to abdominal radiographs, we want to be extremely systematic when we're going through our thoracic radiographs. The standard, is always to take a 3-view thoracic series, right lateral, left lateral, and then either a ventrodorsal or dorsal-ventral view, kind of depending on the patient's tolerance for positioning and perhaps whether or not you're evaluating cardiac structures and that type of thing. And it's important because obviously when they're in one lateral incumbency versus the other, you're really only highlighting the non-dependent lung field. So to really get a thorough evaluation of all lung fields, the 3-view thoracic series would be the gold standard. Similarly, we attempt at peak inspiration. Certainly there are some respiratory conditions that are going to make that difficult, but the goal, again, to maximize lung expansion in case there may be subtle lesions that you could miss, if it's a very expiratory radiograph. And then, of course, going through the radiographs systematically, and we'll go look at some normal set of radiographs here, and I can kind of talk you through how I would normally go through a set of chest radiographs. For starters, I think it's good to make a habit of not trying to interpret one view at a time, but rather whenever you're evaluating a particular structure, so if that's musculoskeletal, to make sure to be redundant and look at that same structure on every view before moving on to the next thing. That way you've sort of made your assessment or conclusion on that particular organ system, rather than trying to interpret one view and go on to the next, which ends up being quite illogical and I think can confuse you in the end. So the first thing, you want to make sure your positioning and your radiographic technique is adequate. Certainly technique is much more simple with digital radiography, and we're not going to get into the nuances of technique and things like that right now in the interest of seeing more clinical cases here. But certainly you want to make sure your exposure is appropriate, that you've included everything anatomically that you need. So definitely you want to have the thoracic inlet, a little bit cranial to it would be ideal. So at the very minimum here, but we'd like to be a little bit more cranial. And then caudally, if you've included the entirety of the liver, you probably have the caudal extent of the lung field. Some people will use this caudodorsal margin. You just have to be a little bit cautious because the lung field can extend quite a bit caudal. So just pay attention to the pulmonary vasculature, and that's going to tell you really where the limit of the caudal lung field is. And then ideally we would have skin margins all around, but that's not always feasible. In a very large dog, it might take many more views, but certainly if it's a trauma case where there could be something extrathoracic that's then involving intrathoracic structures, as much as possible you try to get as much of the chest cavity and skin and subcutaneous tissues as you can. So in this case, positioning and technique is adequate for all of the views provided. Obviously you want to make sure that they're labeled appropriately. And the first thing that I will look at is what phase of respiration are we? Is it inspiratory? Is it expiratory? If it is expiratory, we'll get to that a little bit later. Perhaps there's pathology that's responsible for that. And the way we assess inspiration or expiration is really the distance between the heart and the cranial border of the diaphragm. So the more that those are overlapping, certainly the more expiratory it is, and the larger this little triangle is here, the more inspiratory your radiograph is. So then moving on, you can just get a general assessment of body condition. Are there any masses or lesions in the skin or subcutaneous tissues? Excuse me. And then move on to the skeletal structures. So usually I start with the spine. I'm making at least 3 trips through the spine, spinous processes, the articular facets, spinal canal, and then the vertebral bodies and their disc spaces. Take a look at the scapulas, whatever portion of the humerus you have, sternum, ribs, and then again repeat on the next lateral view, and then repeat again on the VD. Certainly each view may highlight something different that the other one doesn't, so redundancy is extremely important, I think, with abdominal and thoracic radiographs. So once we've covered musculoskeletal structures, I go ahead and do a thorough evaluation of the cranial abdomen. Dr. White already went through evaluation of abdomen with you, so with the same level of detail and thoroughness, even though you have a limited portion of the abdomen, you want to do the same thing, serosal detail, organ by organ, whatever you have. You want to make sure you evaluate that. And then moving on to the thoracic cavity, the sequence that I usually take is I'll start with the pleural space, looking for evidence of fissure lines or retraction. Once I've completed and we'll go through these in more detail with each, review the actual pathological diseases that lead to respiratory distress. But so for starters, I do the pleural space, and then I move on to mediastinal structures, which includes the cardiac silhouette, trachea, esophagus, lymph nodes, including sternal, cranial mediastinal, and tracheobronchial lymph nodes. And then at the very end, I finish off with the lung. For me, that seems to be a logical sequence because either pleural disease may affect the way you interpret the lungs. Certainly if you notice anything in the cardiac silhouette, that might affect your interpretation as well. So what we're going to do is sort of, based on that systematic approach, we're going to take the major portions of the thoracic cavity that may contribute to a presentation of respiratory distress in your patient and kind of take them one at a time, starting with the pleural space. The purpose of this slide is really to show you that depending on the view that you take, and you can see that they're labeled for you here, if you do have pleural effusion or pneumothorax, the positioning of the patient will dictate which pleural fissure lines you're able to identify. And it's a nice reminder of our lung lobe anatomy as well, because if you look at the right lateral view, for example, the right middle lung lobe, also the caudal subsegment of the left cranial lung lobe, those are very ventrally positioned lung lobes. So you're expecting to see fissure lines ventrally. On a lateral view, if you see a dorsally positioned fissure line, it's going to be between your major cranial and caudal lung fields. So it just helps refine your anatomy a little bit when you're describing fissure lines on radiographs, and also it helps you predict a little bit better where you would expect to see them. So you would be more likely to pick up, subtle fissure lines, before there's significant amounts of retraction. So first major disease you may deal with of the pleural space is pneumothorax. I've listed a few differentials for you here. So certainly penetrating wound to the chest, even blunt thoracic trauma without direct penetration can lead to pneumothorax as well. Theoretically, we can also have extension of pneumomediastinum, so pneumothorax may be a secondary condition rather than primary. And then, of course, ruptured cavitary pulmonary lesion. That might include an abscess with gas-forming organism centrally. It might be a tumor, again, with a necrotic center. More commonly, we may think about bulla or blebs, which are purely air-filled cavities. Oftentimes, we don't know, even if we do see those on the radiographs, we don't know who's exactly the culprit, but those are just some differentials to consider. And then our hallmark radiographic findings are going to be retraction. So here you can see the board of the lung lobe delineated by white arrows, retracted from the chest wall by an air opacity. And the way that we know it's retracted is because we can only follow the vessel so far, and there's no pulmonary vascular structure seen beyond the periphery of this lung lobe here. So you want to be sure that you're not getting mistaken by either radiographic technique or overexposed peripheral lung lobes and that type of thing. Just pay very close attention to the pulmonary vasculature and see how far you can trace it, and that's going to help you be more confident regarding, whether or not there really is a pneumothorax. On the lateral views, it actually tends to be the more sensitive region to look caudodorsally here. If there is sufficient pneumothorax, you may actually see what we would call elevation of the heart from the sternum by air opacity again. Be cautious. Some animals may deposit fat here, so it can be tricky sometimes to know really is that the heart being elevated or really is it just a fat patient and that type of thing. But it's not that really the heart is being elevated, it's that there's a mediastinal shift due to the pneumothorax, and that's what causes that apparent sort of separation. But again, just pay very close attention to the vessels, and that'll give you a much better idea of where the lungs actually extend to. A special variety of pneumothorax I just wanted to touch on because in some ways it is more critical than the standard pneumothorax, and that's a tension pneumothorax. So it's defined